Welcome back. You're watching McLaren Port Huron's Today's Health, and I'm talking with board-certified urologist Dr. Glenn Betrus about prostate cancer. So Dr. Betrus, once you get all of that information, then does a patient automatically start treatment?
So that's a good question, and I would say in the 1990s that was largely the case. Patients would get diagnosed and then they would get treated. What started in that era was something called watchful waiting, where we decided that there were certain men that maybe we could safely not treat. And they were typically elderly men with a shorter life expectancy, where if the life expectancy was, say, only a few years, you could be very confident that prostate cancer would not progress in that time frame. So we elected not to treat those patients. And then we found that we were able to safely avoid not treating those patients. So then we started to move it down to younger men and kept kind of moving it down that threshold of age as to who we might be able to avoid treatment on. And of course, the treatments have side effects. So if you can avoid treatment, you can avoid side effects. And that has been the rationale for trying to avoid treatment when appropriate. The question has always been when appropriate. So I think the molecular studies that we're doing now are very helpful in that respect, all of which is designed to try to, again, determine a patient's risk. A high-risk patient, you want to tackle their cancer with aggressive treatment so that you can cure them, and at the same time, somebody with low-risk cancer, you want to try to avoid treatment if you can. So they're all prostate cancer. I think that's an important point to mention, is all these men have prostate cancer, but some of the prostate cancers behave in an aggressive fashion, some behave in a very passive fashion. So you wish you had a crystal ball, and unfortunately you don't, because if you did, all the decision making would be very easy. But in the absence of a crystal ball, you try to use these other parameters, the stage, the Gleason score, the PSA level, the molecular testing, to try to assess a patient's risk and therefore assign that patient an appropriate treatment option, or in many cases, avoid treatment if appropriate.
So you're watchful waiting, active surveillance. Are you testing these people, or are you just seeing them? Are you making an assumption that, okay, you meet these criteria, so we'll see you in a year, or how does that go?
So there's actually, those are two different things. Watchful waiting and active surveillance are actually two different categories. Watchful waiting means you're not doing a lot. You're really gonna leave that patient be. You're gonna monitor the patient periodically, typically at 6-month intervals. But you really kind of are committed to treating that patient only if they become symptomatic. And that would typically be in the more elderly patient that you would take that approach. Active surveillance is active. You're keeping a closer eye on things. So you're monitoring the PSA level typically every 6 months. You're repeating the biopsies once a year. The rationale for repeating the biopsies is to make sure that you're not finding cancer that would necessitate treatment. Now that could be an area of cancer that was there all along, and maybe you missed it the first time you did biopsies. The needle just didn't hit that spot. So repeating biopsies a year later affords you the possibility that you will find that cancer if indeed it's present. And then secondarily, the patient's known prostate cancer that you felt didn't warrant treatment this year, maybe that cancer will become larger or more aggressive next year, and repeating the biopsies allows you to know that.
And so is this typically in a younger group of men, active surveillance?
No, not so much. In fact, if anything, well, younger for active surveillance than watchful waiting, yes. But you know, in your youngest men, it's a yin-yang sort of thing. On one hand, those are the patients you really would like not to treat because you don't want to alter their quality of life. But at the same time, they're the men with the longest life expectancy. So in terms of cure, they have the most to gain in terms of longevity because they have the longest life expectancy. So it is a challenge weighing all of those options and determining what's appropriate for each individual patient.
And is this a significant number of people with prostate cancer that fall in these two buckets?
It is actually. 35 to 40% of the patients that we diagnose with prostate cancer now we're not treating. and we're putting them either into the watchful waiting or the active surveillance category, in most cases the active surveillance category.
Important for people to know in terms of adjusting expectations.
It is for sure, and it's really kind of a change, and you know, it's, I think, something that patients almost find surprising, to diagnose them with cancer and then tell them that you're not going to treat them. But it's all about being able to accurately assess their risk and make decisions accordingly.
All right, let's take a break and come back and talk about treatment.
Okay.